presentation for the afternoon. And Carol, as we were getting ready for this, we were talking about the next topic, and you said something.
I said that I'm sure they've enjoyed our clever remarks so far, but I have nothing clever to say about homelessness in the elderly because I don't know anything about it.
Well, you're very lucky because we have with us Evita Morin, who is a social worker. She is part of the External Relations and Community Initiatives at the Haven for Hope. She earned her bachelor's and master's degree from Columbia University at New York City, or New York, NYC? New York City?
New York City.
Okay, sorry. Soy de Gringolandia.
Not Colombia.
Evita has had social work experience with clients addressing substance abuse, behavioral health recovery, community reentry, and homelessness. And in 2011, she joined Haven for Hope, developing programming for their aftercare and centralized intake initiatives. She is committed to the efficient and respectful delivery of services for men, women, and children seeking homelessness services. And currently, she serves as Haven for Hope's external relations lead, promoting the innovative campus and integrated service space model. She has other people with her that she will introduce as part of her co-presenters. So help me in welcoming Evita Morin.
Thank you. Thank you, everyone. I would, before I like to start, introduce two guests that I have today. One is Miss Joan Corcoran. She is a friend of mine. She has also experienced Haven firsthand as a consumer about almost 3 years ago. And she experienced homelessness at that point in time. It was a one-time event for her, and has been housed for the last 3 years and undergoing some physical health issues. So we're going to talk a little bit with Joan about that. And then I've got Mr. Ron Brown. He is our outreach manager. He is from Chicago. They both have traveled throughout their entire lives. And he worked at DC in the 70s and 80s as an intern before becoming almost a professional football player and then a pastor, finding his way to San Antonio to help us outreach to people out under the bridges and in tunnels, and really goes out deep into dark places where people are living in tents and other kind of situations. So later on today, we'll be talking to him and to Miss Joan. In this session, and I apologize, the slides are not comprehensive, but I would like to talk about just a brief history of homelessness in America, just to orient to what that is today, and focus on some senior homelessness issues and discuss something called the cohort hypothesis. I want to compare Haven for Hope's data and what we do and what our community homeless situation looks like specifically to San Antonio. And finally, conclude with some implications and recommendations for providers before talking to Joan and Ron. So, brief history. In the 1640s, we had destitution. Homelessness did exist in the 1640s in America. People were working hard, however, destitution, poverty did exist. Support was almost entirely reliant on communities, and at that time, it was in a puritanical environment. You had the idea that mental illness and physical health issues were often attributed to moral deficiencies. So people who were experiencing behavioral and physical health issues often did not live very long in that kind of environment and community. In the 1820s and 1830s, we have the Industrial Revolution, which was great for jobs, but poor for factory workers and the safety regulations going on then. So, as a result of that, and how it relates to homelessness, is that we've got people who are at a much higher risk of injury and death, and those people were the breadwinners. At the same time, we have the first shelter system is essentially the jail system. People who were experiencing substance abuse issues and things like that often found themselves recovering and sleeping in the jail cells at that time. So as a result of the loss of a lot of breadwinner income, we have the first documented homeless issues arising in the 1830s to 1860s. Also, what was different and changing was the railroad travel at that time allowed people to traverse throughout the entire country and left communities much more dispersed and much less supportive of each other. We also have the Civil War, which brought on some great medical advances like pain medications. People were surviving amputations. At the same time, there was an increasing survival rate of people with disabilities and people who were unable to work. In the 1870s, we have our first known rescue mission established. And this was really a period of time in communities where people were starting to gather around social issues instead of just people that they knew. This became a stranger helping stranger kind of point in time. And this is when social work was also developed as a field of practice being studied. And also community organizing started to create a voice for disenfranchised people. We have Jacob Rees, who was taking photographs of people living in very impoverished conditions, putting that in journals, talking about the situation, and really put it on a page in the public eye. In the 1930s, obviously the Great Depression left many jobless and food insecure, as well as homeless and dispersed. And that brings us to the 40s and 60s. I said this was going to be a very brief history. Baby boomers were born, which does play a part in something that we'll talk about later. Today, they're at the oldest at 67, at the youngest around 49. And central urban spaces were developed to address homelessness. There were often, this is where the term skid row came into play. We have rows of transient housing. These were lodging situations that were not for vacation, not for business. These were for people to spend one night before they had to go somewhere else. In the 60s and 70s, these baby boomers were now young adults. And at the same time, some historic things that were happening. Psychiatric hospitals had deinstitutionalized, and also people from Vietnam War were coming home. And this is the beginning of when we first hear about veterans becoming homeless. In the 1980s, housed communities were knowingly experiencing an increase in emergency food demand. And this was something that it's not that it didn't exist before, food insecurity, but the nation, the government, was finally starting to pay attention to some big issues around poverty and starting to collect data around poverty and homelessness. So they were able to start acknowledging that there's food insecurity around the nation. Expansion of emergency housing and shelters started to build, and at that point in time, in the 1980s, there were about 600,000 people sleeping in shelters or on the streets. And 38% of those were actually without shelter. So 38% were sleeping on the streets instead of a shelter, instead of a jail cell, instead of a home. So now where we're at today. Today, it's about the same, about 600,000 people experiencing homelessness on any given night. We have new language to talk about homelessness, as well as new data that people were starting to collect at that time. Chronic versus non-chronic. So they started to differentiate homeless situations by people who have had extensive periods of time homeless, as well as usually a complementary disability, most likely a mental health issue, versus non-chronic, which would be someone who's experienced homelessness maybe one time in and out, or a couple times in their life, but didn't have a persistent issue with homeless situations. We also have standard shelters and traditional housing not meeting demand. As you may know, hospitals and jails are often engaged as a result of this ongoing issue. So jails continue to be a pervasive place where people are detoxing, where people are staying inebriated and recovering from mental health, behavioral, acting out, things like that, instead of shelter, instead of medical services and help. The EMS system is primary medical care for people sleeping on the streets, and that is still something that we're trying to engage today, even where I work at Haven for Hope. But it's an ongoing issue because of all the barriers that people have to access medical care when they're living on the streets. And finally, it's the moral undertone of homelessness is changing. It's less and less about what you've done wrong or what you can do to pull yourself up. It's much more about understanding that it's a very complex social issue that has a lot to do with mental health and physical health decline. So the first point that I want to make about aging and homelessness is that people who are aging are incredibly vulnerable to homelessness, whether or not they ever experience it to begin with. 16% actually live in poverty of people who are 75 and older. 1/3 of adults at 65 and older live by themselves without a support system. And 50 to 25%, according to the American Psychiatric Association, of people aged 65 and older are struggling with some sort of mental health issue. Additionally, the official poverty measure that the government uses indicates that about 8.7 people who are elderly experience poverty or below the poverty line. But there was another measure by the Census Bureau that was released that actually took into account regional variations, cost of living, and benefits like SNAP, food stamps. and as well as non-discretionary expenditures, including medical out-of-pocket expenses. And when they did this, the number jumped to 15.1%. And the majority of the reason for that was medical out-of-pocket expenses that were sucking people's incomes dry. So the other point that I want to make is that aging happens much earlier in homelessness. It's hard for me to talk about seniors without talking about the fact that people age much more rapidly when they're living on the streets. What is the life expectancy of someone living on the streets, do you think? I guess it's in the slides probably. I heard 60s? Yeah, it's definitely, it's 64 years. So compare that to 78.7 years for the average general population. And if you are 65 today, you can expect to live between 84 and 86 years old. And so to further that, there was a comparative study of people in their 50s who were experiencing homelessness and those who were not. And the study showed that there was a significantly larger group of 50-year-olds experiencing homelessness who had difficulty performing activities of daily living, mobility and cognitive impairment, and also frailty and depression, among other things. So I'm positing that the chronically homeless senior is actually 52.5 years old. If you take someone who is 65, and that's 65 to end of life is about 1/6 of someone's lifespan for the general US population. At age 52.5, they're at their last sixth of their lifespan. So senior homelessness, in addition to all of that, is distinct and it's rising. 28% of all homeless single adults were 51 and older in 2011, which is up from 23% in 2007. Also, it's distinct in that it's significantly a male issue. It's interesting because if you look at the elderly population, the majority of women far outweigh men in the senior age. But when it comes to homelessness, the number of homeless seniors who are men far outweigh the number who are women. And also, 64% of veterans experiencing homelessness in 2010 were age 50 and older. And that's rising compared to 2000 when only 37% were experiencing homelessness. So there was a man named Dr. Colhane who posited that it's possible that the people who were homeless, chronically homeless today and seniors were from a cohort of the baby boom era and born in that time and were young adults who were experiencing homelessness back then. And so what he did was looked at the New York City data. At that time, New York City was the only city that captured data on homelessness, so he started there. And he found that in 1990, the 31 to 33-year-olds who were the baby boom era were getting older. As they were getting older, that same peak kept existing over time in homelessness. So now it looks like these people who are now 46 and 48 might actually be the same group. It's clearly not a random trend. And he looked at it also with the United States data once that was available in 1990, 2000, and 2010. Again, you see that same peak that were 31 and 30 way back then, who are now 49 and 51 today. And so he's positing that this group, this cohort, never ever got out of homelessness from the period of time that they were a young adult to today. And what we didn't do for that group of people is a result of what we're experiencing with the medical issues and the homelessness today. So how does this differ from the general aging population? It shows only 5.9% of people who are in the entire US general population are elderly. Compared to the homeless population, we've got more like 11.3% in the homeless population. So you've got a significant glut of people who are seniors experiencing homelessness that just don't ever see that average. So how does this compare to San Antonio? I wanted to share a little bit about Haven for Hope and just kind of what this model is. It can exist anywhere in the United States, but it's something that San Antonio happens to be doing differently about homelessness. And I'll share that with you. So these are some of the individuals who attend. We do work with men, women, seniors, children as well, families. And we decided to work differently when we compared other homeless service models. Your standard shelter is 3 meals, a place to sleep every night. And you may have one way in, which is homelessness, and often there was one way out, still homelessness. There was not any wraparound service. There wasn't a real motivation to do anything besides provide basic needs for people. It was addressing chronic homelessness wonderfully for people who kind of just expected a life on the streets forever. But it didn't engage anyone to do anything above and beyond that, and it also was incredibly difficult, and it didn't really accommodate the diversity of homeless experiences beyond chronic homelessness. Finally, it's a limited capacity with growing need. If you're not addressing housing and moving people out of homelessness into housing, there's a very low ceiling in that shelter, and once people fill it up, when there are new homeless individuals coming to seek assistance, they're full, and there's nothing else you can do about it. And finally, if you take a look at that service sprawl, I mean, to obtain services, even if you wanted to, you're looking at traveling, around the 412 square miles out of San Antonio and the 1.36 million people who are also seeking services. So to maintain your physical health and your mental health and your legal issues and your identification, good luck. So what Haven for Hope did was try something that it's integrated service model, and I like to call it a best fit model because it allowed for many doors in and many doors out. If you were experiencing homelessness and behavioral health issues and weren't ready to take meds, or substance abuse and weren't ready to quit, or still struggling with a lot of these things, we needed to find a place to at least engage you, provide you those basic needs because you still felt like you were suffering in this chronic homeless situation, but being there in the event that you were ready to change. And because of that, we've been able to move thousands of people from Prospects Courtyard, which is that space there, into one of these two or out in the community. So transformational campus here, that was Prospects Courtyard, the emergency shelter model, and then that we still have on our campus. This is the transformational campus. It's right next door. Everything is centralized within a block. And to live there, you have to be actively engaged in a housing plan. You have to be working on something to address your needs. And in that space, there are 40 partner services that are giving a diversity of services to people in need. We have a medical facility there. We have a vision, dental, counseling, legal aid, job training, among other things, and 2 residential programs, one for substance abuse and one for mental health. And finally, we acknowledge that housing continues to be a problem in San Antonio, especially for people that are that vulnerable, and so we built housing. We have an affordable housing space that's, again, within that block radius that allows for people with needs, with supportive needs, to continue to be close and tethered to services while still maintaining independent living. And since the building of all this, and since we've been open, we've managed to house 1,000 people from homelessness into housing, into various forms of housing. Unfortunately, though, we're full. Even though we move people and we graduate people and people get moved into housing, there is always a huge demand of people coming to the door, and this is San Antonio. I mean, this is the situation that we're all experiencing. In addition, if you're talking about someone who's a senior, who's got medical issues, we're talking about living in a communal space with over 1,000 people, which is not incredibly conducive. Also, the biggest struggle that I acknowledge in this room is that Haven for Hope is not medically equipped to handle and care for individuals who can't take care of themselves. So even though they end up at your doorstep with so many medical issues and you treat them and you want to send them out, referring them to Haven for Hope, it's just going to continue to exacerbate the system. And Haven for Hope is not conducive to healing from ongoing medical conditions. Housing is. If people have got chronic and ongoing issues, it's really important that they have a stable place to stay. So I was hoping I could share some of the data that we've had. We have this database that dozens of our service providers share, all of this data in the centralized space that Haven for Hope manages. And so how do we compare to that cohort? How do we compare to any other city, and what can we do about it? This is an age distribution from 2010 to 2013, and it shows that we have a quarter of our people who are seeking services are 50 and older. The Haven for Hope, this is a population pyramid by gender. This green is men, and the blue is women. And if you take a look, there's one of the biggest cohorts in red is men between the ages of 50 and 54 that are seeking services at Haven for Hope. That number trickles as we get higher. We'll talk about that. And if you look in the yellow, we're looking at potentially the next cohort of homeless individuals if we don't do something about it. And that's children between the ages of 0 and 4 is our biggest cohort at Haven for Hope. And single women, and presumably many of them their mothers. And that is the biggest issue that we face in San Antonio today. Seniors and children. Haven for Hope, this is an age distribution of sort of a close snapshot of people who are 50 and older. And if you see, there's a significant group of 50 and 55, but it really drops once you get to the 61 and 65. Some of the reasons for that is obviously access to benefits to prevent the need do exist. People do pass away in homelessness even at Haven for Hope. If this is the only place that they can go and so many barriers keep them from housing, then that is the last place that they stay often. And finally, the truth also that breaks my heart is that the shelter is not able to accommodate the healthcare needs of people who are that old and who are decompensating. And so often they get bounced around between the emergency medical healthcare system, our system, and EMS, and back and forth until they pass away. Unaddressed homelessness can be fatal. This is a picture of an outreach done in Los Angeles, a man that they found and rehabilitated from his homeless situation. This was done from the 100,000 Homes campaign. They came to San Antonio to conduct a survey of 441 individuals who were living on the street. And what they found was significant. There was a significant amount of people who were experiencing various diseases, kidney disease, liver disease, HIV, AIDS, cancer. 21.5% were found to be trimorbid, and 19.7, almost 20%, were age 55 and older living on the streets. They deduced that 40.5% had a high mortality risk, and 55.7 had no health insurance to address these needs. The people they surveyed on the street were between the ages of 18 and 90 years old. And the average amount of, the longest recorded time that someone had been homeless was 36 years. This is scary. The total of 416 inpatient hospitalizations were reported in the past year by those 441 individuals, costing an estimated $608,000 to the medical system. Yes. Additionally, in the last 3 months alone, they recorded 579 ER visits for 3 months for those individuals, for an annual cost of $1.1 million. I wanted to share a couple profiles of the people that they surveyed. This one was, and this is a photograph of some of the living conditions that people do exist in. Ron actually took this photograph in his outreach, among other things. And this was a 52-year-old with four years living homeless. He was an honorably discharged veteran. He had 6 ER visits in 3 months, 2 inpatient in the last year. He suffered from a various amount of diseases: substance abuse, mental illness, physical disability, and brain injury. So you tell me if you think he's actually going to live to 64 if he stays on the streets. This is an 83-year-old. He had 2 years homeless, and I question what happened at age 81 that this man needed to become homeless on the streets. He was also an honorably discharged veteran and served in the Korean War. And this is another photograph that Ron took that indicates to me the true lack of hope that people have when they are seniors on the streets. This was someone whose tent he signed that said, "I live here, this is my home, please don't bother me." And these are the kinds of habits and kinds of thinkings that people have that if it weren't for actually going out and outreaching and establishing bonds and moving people into housing and healthcare that they maintain. So the other unfortunate reality is that San Antonio seniors are dying in homelessness. I posited that 50 is the age that we need to start thinking about people who are homeless as seniors. And I looked, the names have changed, but I looked at the death records of people who have touched Haven for Hope. And these are some of the details. Donna was 75 years old. Before she went to EMS to get treated, she said she was hot, she had labored breathing. and then she passed away. Scott, who's 71 years old, he had behavioral health issues. Otherwise, it was unknown what happened to him. 2 of these individuals had pending disability. They were just waiting for income and waiting for services, but they were pending at the time that they passed. Of all of the deaths that happened in the last year, only 3 were not people who were 50 and older. So in 2010, 10 of 13 were between the ages of 51 and 82. The median age of seniors who died was 65.5 years, which is right on with the 64 years that people who are living in homelessness tend to live. So what is the solution for this? Dr. Jim O'Connell said something very profound to me. He said, the painfully obvious lesson for me has been the futility of solving this complex social problem solely with new approaches to medical or mental health care. I dream of writing a prescription for an apartment, a studio, an SRO, or any safe housing program good for 1 month with 12 refills. And so what are the healthcare implications for us? First, aging adults experiencing homelessness are seeking medical care for far more severe conditions and at an earlier rate. I think we all know that. For those experiencing homelessness, it's really important to remember that 50 is the new 60. Does a 50-year-old experiencing homelessness have access to the same healthcare options? And for seniors experiencing homelessness, both the cause and the persistence of decompensation of behavioral and physical health cycles is not having a stable place to live. Finally, discharges to shelters that cannot accommodate medical needs only exacerbate the San Antonio's reliance on the medical care, on the emergency medical system. Some brief policy implications. It's important to know that some of the barriers that these individuals have is lack of identification, lack of a permanent address, declining cognizance, lack of a legal guardian. These are people who don't have those things to help guide them along the way. And that stalls so much. And if there was more flexibility about certain populations, that would be wonderful. I'm acknowledging today that there is a medical shelter care gap for individuals experiencing homelessness who are unable to care for themselves. And the primary group of that is seniors. So without addressing root causes, finally, and that includes a labor market, education, generational poverty, access to behavioral and physical health services, we're looking at a potential additional cohort that may emerge. And that's young children and their mothers. Moving forward together, as a homeless service provider, I would recommend that you ask people if they are homeless. And I know that sounds crazy, but what is your stable living condition or what is your living condition? Is it stable or unstable at intake and at discharge? These are very important questions that can help guide what kind of environment people are going to be healing in. For this population, developing new types and longer-term health care to address their onset morbidity is really critical. Providing accessible medical care for seniors without support systems is vital to maintaining stable housing and positive health outcomes if that's what we want. And I really believe in the integration of behavioral and physical health care, as well as housing assessments within any individual that's cycling through physical and behavioral health care systems. I wish that healthcare benefits would be reassessed to adequately address the circumstances and barriers of homelessness. Today, they are not. Today, people are still struggling to access and are fearful of accessing specialty doctors and anything outside the emergency medical care system. And finally, expanding eligibility and service capacity of healthcare to serve vulnerable people in our community, particularly those that experience chronic homelessness. So I want to thank you for listening to my presentation. And I also would like to talk a little bit and offer to invite you to ask any questions to either me or Joan or Ron. I'm going to ask Joan and Ron some questions myself. We haven't prepped much, but I know that I asked them to come because of their experience in all of these systems, and I love them both. So without further ado, are you ready, guys? Oh, yeah, and that's from So, Joan, thank you. Is your mic working?
I think it's working. Is it working?
No, I don't think so.
Turn it up a little bit.
It's working? Okay, great.
It is? It's fine? Okay.
What strengths do you think you had that other people didn't have to navigate the healthcare system?
I don't want this to sound elitist or entitled, but I was blessed to have been brought up in a family that I wasn't always homeless. I had a very good family background. I had a very good education. I was well taken care of. And once I hit adolescence and in my early 20s, I made some very bad choices. I made some very bad lifestyle choices. So I ended up with what I have now, which is severe COPD and some other attending things that go with it. But I say education because I knew how to navigate. I knew how to go on the internet and look. I knew how to search. I knew what kind of doctors I needed. I knew what I needed them for. I asked lots and lots of questions. I was told that when I first went to Haven, and this may sound funny, but especially for the social work people in here, I actually made an appointment for the date that I was to enter the homeless shelter because I just had given up on myself and I got fired from a job, which I managed to do most of my life, but mainly I fired myself out of all of them. And I had no place to live. And I just said, bingo, you know what? I called the Center for Healthcare Services. They said, come in for an appointment. I went for an appointment. They called the old Sam shelter, which was where I initially entered the system. And they said, yes, we have a certain amount of beds for CHCS clients. So, you know, I stepped in there with an appointment. I didn't just walk in the door and say, I'm homeless, give me a bed. It happens to a lot of people. And I was determined. I had never been in a homeless shelter in my whole life. I had that thinking that I was not too good because guess where you are right now? So you can't be too good to be in here. The other thing that I'd like to say is that I think helped me immensely was I was going to sit up here and say, my name is Joan and I'm a recovering alcoholic and drug addict and I'm getting the care that I need. But through those programs, I learned how to take care of myself. I learned to fight. I learned to fight for what I needed and what I wanted. So in my current situation, which is I have severe COPD, and I'm in the university system, and with all those attending physicians that I have to see because of this condition, I got lucky. I just got lucky because I knew where to go and who to ask and what to do. I could be that person that Ron finds on a freezing cold night with nothing under a bridge and still drinking. The not drinking part is very, very funny because, you know, things pop up in my life that a person who is an alcoholic would use a drink to take care of. And I sometimes think of suicide rather than picking up a drink. I just said, I'm not going to pick up a drink. So I'd like you to know that anyone can have the face of homelessness. Today, I'm standing in front of you with brand new clothes on. I look like a normal person you would see walking down the street. You wouldn't say, oh my God, she was homeless for a year and a half. But once you get that way, sometimes, and I've seen it time and time again, a person becomes institutionalized. And that institutional thinking sets in, and they say, you know what, I'm here, I have 3 hots and a cot, everything's taken care of, why should I do anything about myself? I can stay here the rest of my life. We were told that was not Haven's model when we first went in. I was very lucky in that I was at the old Sam shelter when Haven opened. So they transitioned us over to Haven as soon as it opened, told us what it was about, what we could expect. And the expectations were, one of the things you have to take classes there, all kinds of classes. And I had a counselor who said, you know, and I found a part-time job. I went to AARP and they got me a little funky job at the McNay. And I mean, how cool is that? Who doesn't want to work at an art museum? That's so cool.
Thank you, Joan.
So I you know, don't look down on people like that. But I'm as a very sick person today, I can tell the medical people in here, my medical care is costing Medicare a lot of money. And there are some things that, and you all know this, that have to have a certain number before I can have medical care. I have to be so low on a scale for some things. You know, my breathing has to be so bad to qualify for this. You have to have a certain number for that. And a lot of us use the emergency room as our doctor because all we have at Haven is Central Med. And Central Med is just like basically a doc in the box unless you can't get a lot of specialized services from them. So that's what I want to leave you with, you know, just think about it, ask questions. If somebody comes in there and they don't look like they're homeless and they tell you they are, it could happen to anyone, anytime. And I got lucky. I fought, I clawed, I said, I'm not staying here. I'm not going to do this the rest of my life. And I was blessed to find people like Evita and Ron and the other people that work there. And here I am today. So thank you for letting me tell you what it's like from my side of the street.
Thank you, Jen. Thank you. All right. Ron,
Yes.
from your experience, what prevents someone from getting help when they're out in the streets?
I hear it all the time. I don't have any money. And some of the illnesses range from asthma to bones being broken, cardiovascular issues, and there's no way for them to get to doctors unless somebody like me ride over and give them bus passes, leave them in the tents, you know, or catch them out there while they're out there and give it to them so that they can get in town to maybe get the inhalers that they need to address some of the wounds that they have. I've seen quite a bit out there, and just being able to get from point A to point B while you're living out, you know, on 1604 and between 410 and 1604, all around our city. I know you all have driven across bridges, across town streets with people living right up under there, and their biggest issue is they don't have any money, no money, and there's no use to going to emergency rooms or clinics because they're just gonna turn them away. So 9 times out of 10, when I meet somebody out there that's pretty sick, they usually don't last no more than 6 months. I can name over 30 people that I've known since we've been open that died in the streets out there. Just no care at all, no family, you know, and no one that they can trust. That's one of the biggest things. They want people to honor what's on the wall, and when it's not happening, they lose hope. And when they lose hope, they just take what they can take and wither away. Food is okay, but that's not what they really need. They really need some help with their physical bodies and whatnot. So that's with money and being able to get to point A to point B. That's the biggest of it.
Thank you. Does anyone have any questions for any three of us? Yes, sir.
I have a question for Ron.
Mhm.
I understand you came from Chicago.
Yeah.
I recently came from Chicago myself, and being that you live here in San Antonio, my question is, how long did it take to get used to the heat? I haven't got used to your hair for a couple of months.
Oh, it's gonna take you about 15 years, man. Just. Yeah. Took my mother 3 years before she came back after the first year she got
You're
it.
going to get allergies too. You never had one in Chicago, you're going to have one here.
So my other question is, I work with the NBA. What would you say is the complication when you see veterans who are entitled to benefits but yet are homeless? I noticed there was a high population of veterans that are homeless. Why are they not going for the services that our organization provides?
Trust, red tape. I've talked to them.
Red tape.
Yeah.
Okay.
Red tape, trust, you know, doing what we say we're gonna do. So they just rather stay out there in the woods and fold up their clothes neatly. I've got photos of very neat camps of individuals who just lost trust in our system.
Thank you. Any other questions? And,
Yes.
You know, when you see homeless people on the corners, you know, with signs wanting money. You know, a lot of people always say, well, I don't give them money, I'll go to McDonald's and buy them some food, or I'll give them a lunch. But a lot of times, are those people that are there, are they those really the homeless population, and are they needing the money for alcohol or drugs, or, I mean, or do they just need money for
Yeah,
different-
homeless, true homeless individuals don't have time to stand out there like that.
Okay.
They trying to access services, they need showers, they want food, clothing. So, and I've cased them out, so I know what I'm talking about. I've seen them get in vans and, you know, work corner to corner, part city to part city, and the majority of those individuals, and I also see them at the methadone clinic over here, right down from Haven, because they need to address their drug issue. So true homeless folks, and I learned this first on, before we opened up. I was doing outreach at for Haven, and they just don't have time. They trying to get whatever they can get to help themselves physically, as well as, you know, acquire the ID, the things that they need to obtain jobs. The true homeless individuals, yes.
Thank you.
Downtown besides Haven for Hope where people can go for a meal?
Yeah, there's some locations, but since we opened up, we have the city ordinance has to be followed, and certain codes have to be, if you have a kitchen or if you dropping food off or preparing food for homeless individuals, you have to be up to code.
Right.
So yeah, the city, they come out and visit those establishments, and they have to be up to par. Otherwise, they'll give them a $3,000 fine for doing
Okay,
that.
but so I'm just curious, like, because you see people that are outside of downtown that, and maybe it is a transportation issue, but, you know, I would think that, you know, that so many of the services are concentrated in the downtown area. It's like, well, what are you doing up at 1604 and what are you doing at 410 and 10? I mean, the services are downtown, and
Right.
I don't know. It says I need food. Well, food is. I would think that there'd be, you know, there used to be the Travis Park. That they
Yes.
would serve food. That's where you would go. You know, if you need food, go to Travis Park.
Well, they
Or is it just not enough?
not enough, and like I said, it's the system, it's the way they've been treated, is the reason why they really don't want to come into town. They'd rather stay outside of town. They'd rather frequent HEBs and Walmart Plus, because they're able to get the food that's not able to be sold with the date, but it's still good.
Oh, okay.
So they get this food and they cook it and they, you know, prepare it, rather than trying to come into town and deal with, I don't know if I'm gonna get back out. I might get into town. I might get arrested. A lot of factors play into that, but
Right.
that's the reason why there's quite a few people still out there. As we graduate, folks, we still have a lot of people still in that surrounding area who are hurting real bad. Yeah, real bad.
I wonder how much of the senior population has dementia? Do you see a lot of dementia among the senior population?
Yeah.
And how do you deal with that?
It's tough, you
I
know.
mean, they need to be hopefully in a contained area.
Yeah, and you can't make them go anywhere. You can't make them do anything. All you can do is just hope and pray that they stay safe, stay, you know, within their comfort zone, and not venture out to get hurt. Had a good friend of mine who got ran over just here a few months ago, crossing Nacogdoches, and he's in Corpus now with his family, but he had pretty bad brain damage from, you know, those type of issues you're talking about. Yeah.
I'm asking for somebody else. If you see a homeless person, what should you do? Should you contact Haven for Hope? Should you go up to the person yourself?
Yeah, you can, if you don't feel like contacting Haven, doing it yourself, you can contact us, and I'll go out.
Yeah, he actually answers many calls throughout
Yeah.
San Antonio.
Phone always ringing. And I go out and I address, I talk to the individuals. My thing is to create a relationship first. Because if I don't create that relationship, they're not gonna come, they're not gonna go. So one of the last things I say is I work for Haven, but I wanna know what they need and how can I address some of the needs that they have, whether I have it on me or whether we have it at the campus. And if I have it on campus, that's my way of getting them over there, getting them a shower, change of clothes, some lunch, talk to one of the intake specialists about what we have to offer, and I'll take them back where they were. And just like Friday, one of those photos you saw, individual, I engaged him with an intern, and 3 days later, the individual called me and said, hey, I want to give it a shot. I'm tired of living like this. He has his ID, he's clean. I always ask, are they clean? And if they're clean, we can get them onto the campus. And what I mean by clean, I mean drugs, and we can get some help for them. So, yeah, you just have to trust your instincts. I don't go into camps by myself anymore. I used to, but I don't do that anymore. Yes, ma'am.
You seem to be the exception rather than the norm. You seem to be the exception rather than the norm. I was wondering how you decided to go into the system when we're hearing from Mr. Brown that a lot of people they don't trust the system.
I didn't know what to expect. I mean, I just knew that I had put myself in a hole as a result of not taking care of myself, but I knew that I couldn't live on the streets. I didn't know how to live on the streets. I didn't ever want to. But like I said, I knew how to navigate the system. As to, where you just have to know the person to ask questions of. And like I said, if anybody knew or if anybody asked, CHCS would have told them, yes, we have a certain amount of beds at the shelter. I never asked them do they have at Haven also?
Mm-hmm.
Yeah. And so that's what you have to do. But like I said, a lot of people don't know that. They don't know how to do that. They don't know how to get out of homelessness as much as they'd like to. They just don't know how to navigate, and that's why there are so many services right there on the Haven campus. The gentleman who navigated me through the Social Security system to get disability is there. AARP was there to get me a part-time job at the McNay. There are mental health services there. SAHA had an office there to get me navigate me through the housing, to get me into housing. Everything is there if you know how to do it. And I think that's my suggestion for intake, is to ask incoming people, do you know how to navigate the system? If you don't, please find someone who does, and they'll help you get everything that you need. You don't have to stay here.
And I guess I'd like to also stress that, Ron's job is to address chronic homeless individuals, but Joan is actually the norm of what we see. There are many, the majority of the seniors we see are experiencing first-time homelessness, are not the chronic homeless, in the chronic homeless situations. And so they do have some background navigating and being used to the system and the red tape, whereas people who have been on their own for many years have a lot of difficulty accepting that.
Actually, I have a follow-up to you. If there are individuals that usually family members are taking care of, so they're not out on the street, they don't have their own home, but they're staying with family, and that family support system can't sustain that long term, would you outreach to those kind of folks who really don't have anywhere else to turn, no government programs at the moment, but one solution is Haven for Hope? They just have heard things. They don't want to go to Prospect's yard. They have excuses and whatnot. And so the family member who's stressed and is kind of stuck, they don't want to put their person out in the street.
We experience that frequently at intake. However, I'm going to speak again to that gap, that if someone is not able to care for themselves, we're not equipped to address that we can't meet people's ADLs with the kind of homeless service staffing that we have. We can't medically care for people. So often it's that group of individuals who their last support system has failed them. Haven for Hope is not the best option. And I don't, there is no best option, but until we do something to address that particular group, they continue to bounce between homeless services and emergency rooms and shelters and never have a stable place to go and decline very rapidly because of that.
If I hadn't gotten out of Haven for Hope when I did and then experienced an exacerbation of the COPD, I would have been one of those people. I wouldn't have been able to be at Haven for Hope with having to be on oxygen 24 hours a day. Number one, I asked them once, they said they were afraid that the oxygen tank would blow up. Well, it won't unless you smoke in front of it. But they're just, they're not equipped. It is bare bones. You have a bed, you have a locker that's very minuscule, you're fed. Like I said, there are all those services available to you, but if you're medically unable to be there, where do you go? Mm-hmm. There's no such thing as a shelter for senior citizens, senior homeless citizens. Maybe there should be. Maybe somebody should invent that, but there just isn't. And
there's a need. There is a need. Yeah. And if I may speak a little bit about some of the situation that you're experiencing right now that you've shared with me. Joan is being assessed for a lung to help her survive. And one of the things that the doctor shared with her is their hesitancy to move forward with that because she still lacks the support system in order to care for her once she has that surgery. And even though she's housed, she is just as much at risk for going right back into the homeless system, except now with lung surgery, if she doesn't get that support system. And that's part of why this ongoing system of care, this collaborative, needs to happen with behavioral health, mental health, physical health and housing. Otherwise, her lung is on hold or she stays sick and declines. Yes.
Are counseling services offered not just so much for the adults, but for the kids?
Yes, we do have children's counseling and psychiatric care. We also have adult counseling and adult psychiatric care. Mm-hmm. It's very important for the children. Mm-hmm. Any other questions related to aging and homelessness? This lovely Jen. Thank you very much for your time. I really appreciate it. Thank you, Ron and Joan.
You're welcome.
That is our last presentation for the day. We have a few wrap-up comments, and I know Barbara, she's coming. Barbara's coming. There is a raffle that's being held for participants that are here, and Barbara is bringing those items in. For those of you who are not coming back tomorrow, thank you very much for your attendance and for participating. Everyone, please fill out the CEU and evaluation forms that are in the packet that you have for today. Leave those on the desk. We'll be happy to collect those. And then for those of you who are coming back tomorrow, we look forward to seeing you at 8 o'clock in the morning.